Thank you, Dr. Jyoti Dev, for organizing such a wonderful conference and making us, all of us, a part of this. Formally, I need to introduce Dr. Sanjay Kalra, who actually doesn't need any introduction all over India at least. But just for a customary, he is consultant at Bharti Hospital, Karnal, Haryana. He is well-known figure of the North India. He has done MBBS from CMC Ludhiana, MD PGIMS Rohtak, and DM from AIMS New Delhi. He is so much of the academic person. He is having editor, so many things, editor. He is there. He is editor at the Diabetes for ESI Manual of the Clinic Endocrinology, first and second edition. He is section editor Endocrinology for API textbook of the medicine, Thyroid Research and Practice Journal of the Social Health and Diabetes, and Indian Journal of Endocrinology and Metabolism has been started by him also, I think so. If I am not wrong, you have started the
rejuvenated.
No, yes, thank you. So over to Dr. Sanjay Kalra.
Thank you, sir, for that warm introduction, and good morning, everybody. Diabetes care is becoming more and more complicated day by day. And then this quote from the Bible actually sums up the problems that we face today in diabetes care. It was much easier earlier when we had just 1 or 2 tablets and 1 or 2 types of injections. But we now have so many injections, so many tablets, and the number of permutations and combinations have gone into multitudes. And that makes decision making all the more difficult. It would be nice if we had optimal drugs to use, where we didn't have to think too much about what to use and what not to use. And this is especially true for a country like India and a state like Kerala, where the average physician, all of us, we'll see in double digits, triple digits people with diabetes. And there is so much of workload. So if for every patient that comes to you, you have to spend 5 minutes thinking about what to do, then the whole time will be spent just in thinking. You will never be able to practice. You will never be able to treat patients. So if we have a drug where you don't have to think too much, where everything is optimal, then it would be a real advantage or a real benefit for us. Let's talk about one such drug, which is Gemigliptin. We know the DPP4 inhibitors. We've been using them for the past 10 years. But what we do not know is that not all of them are the same. So all DPP4 inhibitors are not made the same. The structure is different. Some of them are peptidomimetic. Others are non-mimetic. Amongst the peptidomimetic ones, some of them have covalent bonding. The others have non-covalent bonding. Out of the drugs that we use conventionally, sitagliptin is the one with the longest history. Sitagliptin is a non-covalent interacting peptidomimetic DPP4 inhibitor. Let's compare this drug with Gemigliptin, which is also a non-covalent bonder and which is peptidomimetic drug. We'll see if Gemigliptin actually gives us advantages over the existing DPP4 inhibitors, and if actually we can use it as an optimal drug in our clinics. And like I said, we really need a drug which we can prescribe to virtually every patient with diabetes without thinking too much about drug interactions, without thinking too much about side effects, without thinking too much about safety and tolerability issues. Gemigliptin is a DPP4 inhibitor. It acts upon the DPP4 active site. But when you compare it with sitagliptin, in the light gray you can see sitagliptin. When you compare it with sitagliptin, you can see that Gemigliptin has extra binding sites as well. So if light gray is sitagliptin, in the saffron color you have Gemigliptin, which has not only the binding sites that sitagliptin has, but it enjoys extra binding sites as well. Because of this, it has a fast binding to the DPP4 protein, and it has a very slow offtake. So it binds fast, but it dissociates slowly. Because of that, it is long acting. And because of that, it is assumed, and we will see the data, it actually is able to control both fasting and postprandial glucose. The potency of Gemigliptin is also proven by the fact that it increases the plasma levels of GLP-1 by 40 units as compared to sitagliptin. So there is actually an improvement in GLP-1 levels. In spite of this potency, it is highly selective. And we can see from this table in front of us that Gemigliptin has the highest selectivity for DPP4 as compared to DPP8 or DPP9 or FAP. The advantage of this is that there will be no side effects, no unwanted effects like for example, immunocompromised status with Gemigliptin. So it's a very safe drug to use irrespective of level of immune competency. It has a very balanced hepatic and renal clearance, which means that it can be used in patients with mild or moderate renal failure. It can be used in patients with mild or moderate hepatic impairment. So this is one of the other advantages. Like we said, we want a drug which is going to work in the clinic and which doesn't cause side effects. So with this particular drug, we need not think about hepatic function or renal function in the patient who is walking into the clinic. There are no clinically meaningful drug interactions. This is another added advantage, especially in today's era of polypharmacy. But all these advantages will be beneficial or will be worth talking about only if the drug is effective. So is there randomized control trial data to prove this? Multiple trials have been done on Gemigliptin, right from phase 1 to phase 3. As monotherapy, Gemigliptin has been found efficacious, much more so over placebo, and it is able to reduce HbA1c to the tune of 0.7% over 24 weeks, and this reduction in HbA1c is sustained for a whole year. Actually, it improves 0.87%. So while in other drugs we talk about sustainability or lack of sustainability, in this drug with time the action improves and the HbA1c lowering capacity is maintained for at least 1 year. There is a reduction in fasting glucose of 20 milligrams and in postprandial glucose of 66 milligrams %. So both fasting and PP glucose are controlled. So you have reduction in fasting, reduction in postprandial and reduction in HbA1c. This is the glycemic triad that we aim for. Later on in the talk, we'll talk about the glycemic pentad as well. But critics might say that the previous study compared Gemigliptin with placebo. So what? Let's compare with sitagliptin and see what happens. Now earlier with sulfonylureas, we used to use the terms primary failure and secondary failure. For incretin-based therapy, we use the terms DPP responder or DPP non-responder. These are the terms that are used. A better term to use would be DPP4 inhibitor inadequacy. But this is not a homogeneous term. So what this trial proves, let's look at the data, is that if there is a person in whom sitagliptin is proved inadequate, that person may respond to Gemigliptin. So therefore, with the coming of Gemigliptin in the market, now we cannot use the term DPP4 inhibitor inadequacy anymore. At the best, we can say sitagliptin inadequacy or maybe vildagliptin inadequacy. So what this study tried to do was, it compared Gemigliptin in different doses with sitagliptin over a period of 24 weeks. Then all the patients who were on sitagliptin or on Gemigliptin 25 milligram twice daily were switched over to Gemigliptin 50 milligram once daily. And this study went on till a total of 52 weeks. So let us see what happened in the initial part of the study and then what happened when the patients on sitagliptin were switched over to Gemigliptin. Gemigliptin in other trials has been found to offer very fast and sustained A1C reduction. The A1C reduction is visible at 6 weeks. That is really fast. So if you have a patient who wants to get prepared for a cataract surgery, this is a very good drug to use. You will find fasting and postprandial glucose reductions within a week. Even the A1C will come down within 6 weeks. But in this switching study, what they found out was that at the end of 24 weeks, Gemigliptin was statistically significantly better than sitagliptin in terms of A1C reduction. And when the sitagliptin patients were switched over to Gemigliptin, a further reduction in A1C could be seen. So patients in whom sitagliptin was found inadequate could be controlled with Gemigliptin. And if we took a very stringent target of 6.5% HbA1c, then 27% of all patients on Gemigliptin were able to achieve target as compared to only 6.8% on sitagliptin. So that is 4 times the number of patients were able to achieve target with Gemigliptin as compared to sita. And like we said, there is a biochemical basis for this. The binding is more diffuse. Gemigliptin binds better to the DPP4 protein and Gemigliptin binds faster and dissociates more slowly and it increases the GLP-1 levels. So all these basic pharmacology facts are concordant with the results from the clinical trials. Like we said, we have both fasting as well as postprandial control. And also in renal impairment, even in moderate or renal impairment, Gemigliptin is found safe. So theoretically, though practically we would advise insulin, but theoretically, even if the GFR is just 1, you can use this drug safely. That doesn't mean that we use it in place of insulin. When insulin is required, it will be required. But the major take-home message is that in the clinic, you do not need to do a baseline renal function. You also do not need to do a baseline hepatic function. You can prescribe the drug safely. And in my practice, this is one of the major advantages that I see. Because like I said, the number of patients is so much, the workload is so much, and the chairperson sir will also agree with me, you tend to make mistakes. And making errors of omission might still be allowed. But making an error of commission, that means if my patient has renal failure and I prescribe a nephrotoxic drug, that is not allowed. And it would be better for us to use safer drugs where you need lesser investigations, where you need to worry less about drug-drug interactions, and at least you know that you are treating the patient safely. When we talk of safety, we talk of cardiovascular effects as well, because finally death is going to occur because of cardiovascular events in diabetes. So we talked of the glycemic triad. What is the glycemic pentad? Pentad means you want to control fasting, postprandial and HbA1c. You want to avoid hypoglycemia, and you want to avoid glycemic variability. Why is the pentad important? It is important because all 5 of these aspects, fasting hyperglycemia, postprandial hyperglycemia, A1C, hypoglycemia, and glycemic variability are linked with adverse cardiovascular events. So we've already talked of the triad. Gemigliptin, let's look at the 4th part now. And the 4th is glycemic variability. So in this study, when Gemigliptin, sitagliptin and glimepiride were compared with a CGMS based study, with CGMS, they found out that with Gemigliptin, they were able to achieve lowering of 24-hour glucose profile. So it was effective. And especially when they compared it with sitagliptin and with glimepiride. What they found out was that the mean amplitude of glycemic excursions was the least with Gemigliptin, and the standard deviation of blood glucose was the least with Gemigliptin. So Gemigliptin had the least glycemic variability as compared to glimepiride and sitagliptin. So 4 angles of the pentad have been proven true with Gemigliptin, and we'll come to the 5th one later on in the talk. So we are focusing on the glycemic pentad because we want good cardiovascular control, good cardiovascular health, and we want cardiovascular safety. And so far this drug seems to be doing better than glimepiride or than sitagliptin. Apart from glucose control and apart from glycemic variability, reducing cardiovascular events also means that we have to control lipids. And actually Gemigliptin is able to reduce LDL, triglycerides and total cholesterol. This is a property that is shared by very, very few other anti-diabetic drugs and by virtually no other oral glucose lowering drug. It is also able to reduce albuminuria. So we talked of an optimal drug, and we talked of the fact that we need a drug that can be given to everybody. In Indian politics or in Indian philosophy, we have a very strong component of constructive philosophy, and that is known as Sarvodaya. Sarvodaya means benefit for all, and Antyodaya means benefit for the last person in the queue, for the person who is the most downtrodden. If you want a Sarvodaya kind of a glucose lowering drug, that might be Gemigliptin, because you can give it to each and everybody irrespective of what their baseline parameters are, and irrespective of where they are standing, they will benefit in terms of both cardiovascular as well as renal outcomes. For Antyodaya, we would like to say that Gemigliptin is the Antyodaya kind of drug, but cost prevents us from saying that. All said and done, I guess metformin would be the candidate for the Antyodaya of glycemic control. But still with Gemigliptin, with one arrow, you are able to hit multiple targets, and you are able to hit them irrespective of where you are standing, where you are beginning with, whether you are beginning with renal impairment or hepatic impairment or a fasting hyperglycemia or a postprandial hyperglycemia, irrespective of where you start, you will finally end the race and you will win. And the more often we use it, the more often our confidence will develop. It's just like using muscles, and it's a very safe muscle to use. We've spoken of the basic pharmacology, we've spoken of clinical pharmacology, and then we talked of cardiovascular endpoints. But what about safety and tolerability? Gemigliptin is actually a very small size tablet, the smallest in the DPP4 inhibitor range. And it has the lowest incidence of hypoglycemia. So in the Glycemic Pentad, we spoke of fasting, HbA1c and postprandial. Then we showed that it has minimal glycemic variability. And the fifth angle is avoiding hypoglycemia. There also this drug scores. So whether you give it as monotherapy or whether you give it in combination with metformin, the hypoglycemia is minimal. It's weight neutral. It reduces weight slightly, but this is not. This is a numerical number. It is not statistically significant, and it doesn't at least cause weight gain. So this is another added advantage in terms of its use in metabolic syndrome, and it's safe for the pancreas as well. Because of its good efficacy, because of its safety, and its well-tolerated nature, we can summarize then that Gemigliptin is an optimum DPP4 inhibitor. It's an optimized DPP4 inhibitor which we can use because of its efficacy, safety and tolerability, because of its effects on CV markers. And also we mentioned the concept of Sarvodaya. It is actually a drug which will benefit all in our clinic. Thank you.
Before I open the session to the audience, I would like to have one question from you. Would you, because there are so many gliptins in the market and everyone gives some benefit in somewhere and one another where. So for the benefit of our audience, can we give them a points 1, 2, 3, 4 because of what they should give? They should give the gliptin to their patient instead of choosing other gliptins.
So that is a very important point which the chairperson has raised. And like we began, multitudes and multitudes in the valley of decision making. It's actually tough. One of the concepts that we follow in our clinic is the concept of the metabolic fulcrum. What is the metabolic fulcrum? It does a metabolic triage and it divides all people with diabetes into 3 groups. So triage means dividing into high risk, low risk, medium risk. This is a nursing concept. So in the wars, what they found out was that there are less doctors and nurses, but there are more casualties coming from the battlefield. So 1/3 of the people are the soldiers who come. Whether you operate upon them now or tomorrow, they are going to die, or they will not be fit to fight for the motherland again. So they become low priority. There are another 1/3. Whether you operate upon them today or tomorrow, they will survive. They have minor injuries. They also become low priority. But the middle one, they are the ones, if you operate immediately, they will survive, they will be fit to fight for the motherland in a few months, a few weeks. But if you wait until tomorrow, it will be too late. So they are the ones who are taken first into the OT. So this is a triage that is done in the emergency room. In the diabetes clinic, the triage that we do is based upon metabolic syndrome. So some of our patients are eubolic, EU-bolic. They have normal metabolism, they do have diabetes, but overall they are eubolic. There are some who are maladaptive anabolic. So they are the ones who have the signs and symptoms of metabolic syndrome. Hypertension, obesity, dyslipidemia, acanthosis nigricans, darkening of skin. The other end of the spectrum would be catabolic. They are the ones who have insulin deficiency. Now, does this fulcrum work in terms of pathophysiology? Yes, it does, because maladaptive anabolic, that is predominant insulin resistance. Catabolic is insulin deficiency. You can recognize when you look at the patient, when you take a history, you can recognize. And this will help inform the type of therapy that we give. If it is maladaptive anabolic, you would want to give SGLT2 inhibitor or GLP-1 receptor agonist. If it is catabolic, you would want to give insulin. But as a second option, you might think of insulin secretagogues. If the patient is not willing for insulin, or actually you feel that the clinical situation is not so grim. The beauty of DPP4 inhibitors is, because they are neutral for weight, you can give them everywhere. You can give them in the maladaptive anabolic group, because they are not going to increase weight and they will actually improve lipids. Of course, you can give them in the eubolic group, and you can give them in the catabolic group as well, because they are indirectly acting insulin secretagogues. They will act upon the incretin system. They will stimulate the incretin system to stimulate the beta cell, which will finally secrete insulin in a physiological manner. So irrespective of the metabolic fulcrum, we can use these. When we tend to use them is when metformin is not adequate. So we use as second line. Sometimes we use as first line when metformin is not tolerated. The patient comes with GI side effects, of metformin, and even if I use a dose of 250 milligram thrice a day or 250 milligram twice a day, even then the patient complains, then we tend to shift to DPP4 inhibitors. So that is as first line when metformin is not tolerated. There will be a few patients with renal impairment or hepatic impairment where we are afraid of giving metformin. So where metformin is contraindicated, there also DPP4 inhibitors are the first drug of choice. As third line and fourth line, when we add them to a metformin plus sulfonylurea combination or a metformin plus pioglitazone combination, we do use them, but honestly they will not have much benefit. It would be better if we use them early on as second line therapy or sometimes as first line therapy where indicated. Once we have decided this, that we can use a DPP4 inhibitor, then we have to decide which drug to choose. So it will depend upon relative fasting and postprandial hyperglycemia, upon the cost, upon whether the patient wants to take twice daily or once daily. But in general, Gemigliptin is a drug which will help control both fasting and postprandial. You can give it irrespective of hepatic or renal function, and you should be able to see a good HbA1c reduction whenever you do your next HbA1c after 6 weeks or after 3 months. The major advantage that I see for DPP4 inhibitors is their high tolerability. So when you are handling a very busy OPD, the last thing that you want to do is troubleshooting, or you want a dissatisfied patient, because that patient is going to take up a lot of time of yourself that yet you don't mind, but he's going to take up a lot of time of other patients as well. So this is a drug which hardly has any side effects. That is the advantage. And then people say that gliptins are expensive, but actually they are not, because you don't do a pancreatic test, you don't do a liver or renal test. For some of the older DPP4 inhibitors, you have to do hepatic liver function test every now and then. But for this one, you don't have to do. So actually, you end up saving a lot of money for the patient because you don't do investigations.
Have they done enough clinical trials to prove that it should be safe and safe forever?
Yes.
Because yesterday only we were discussing about teneligliptin.
Yeah.
Apparently cost effective, but cardiac side effects prevents us from using the teneligliptin.
Yes. Here actually the clinical trial data is very robust, and a clinical cardiovascular safety trial is also ongoing, that is called Optimus. Now when you look at teneligliptin versus Gemigliptin or teneligliptin versus all the rest, teneligliptin may be more economical, we do not deny that, but that is just the front, the cost that you are seeing right in front. The hidden costs are there. Teneligliptin will increase the PR interval, and it can precipitate arrhythmias, QT prolongation, and it can precipitate arrhythmias. And then there is hardly any data on its hepatic safety. Actually, there is none. Third is there is no long-term data, and no long-term data is planned also by the originator company. So there is no cardiovascular outcome trial that is even planned for this. Theoretically, teneligliptin plus metformin randomized control trial has been done in India, and practically also it has been done, but the duration is 2 months. So in 2 months, what kind of data you can get? DCGI has approved, of course, but you have to read between the lines and see how it was approved and what kind of data was given to support it. So there is no long-term data. And in general, when we treat diabetes in the clinic, it is more of a marathon race. Like, success means that the patient should be with me after 30 years. First of all, success is that I should be there after 30 years and I should be healthy. And then the patient should be there and the patient should be healthy. From marathon point of view, it is not a good drug to use. I would agree with the panelists who were there yesterday. Gemigliptin is different. The data is there, it is in front of us, and very robust data for 1 year, and the cardiovascular outcome trial is ongoing. For the other trials, for the other drugs that we have, we do not have any trial ongoing for vildagliptin, and neither is there any plan from the company side to do that. Sitagliptin, the data was mixed. So overall safety was there, but it increased hospitalization for heart failure. Saxagliptin. Sitagliptin, the data was safe. From a biological or pharmacological point of view, Gemigliptin and Sitagliptin are the closest to each other. But when you look at the basic pharmacology, you find that actually Gemigliptin is much more potent. And in spite of its potency, it does not increase hypoglycemia. And linagliptin also, the data is still awaited. So practically, if we based upon evidence, that would put us that Sitagliptin has the evidence, Saxagliptin has the evidence, and linagliptin and Gemigliptin, the evidence is underway. Let us see what comes out of it. Vildagliptin, teneligliptin, there is no evidence, and neither is the company planning to give us any evidence. Sir, it does not bar the use, but the point is with drug-drug interactions. So if supposing we have azithromycin, that also causes QT prolongation, and you have teneligliptin, there is no way of knowing what they will do when given together. And earlier we did not worry because we did not know. But now that this is all new knowledge, it's just in the past 10 or 20 years that we understand that arrhythmias and hypoglycemia and diabetes, they all have a role and they can cause sudden death. So actually when you are giving a simple combination, teneligliptin plus azithromycin, gliptins, so when you look at the LV function, the term used is cardiovascular phenotype. So when we look at the patient from a cardiovascular lens, there are some people with coronary artery disease. There are others with pump failure or with LV dysfunction. There are yet others with cardiac autonomic neuropathy. For example, they may have a resting tachycardia or they may have postural hypotension. So again, we need a drug which is safe for everything. So if we look at it carefully, liraglutide increases heart rate. So if you have a person with resting tachycardia or with cardiac autonomic neuropathy, there might be chances of life-threatening dysfunction actually. Though it is not reported in any of the studies, but we should be aware of this, that liraglutide causes tachycardia. When we look at saxagliptin, it actually increases hospitalization for heart failure. So if I have a person with ejection fraction 35-36% who is well compensated, it is possible that saxagliptin might tip the balance and bring him to decompensated state. And maybe not saxagliptin alone, but supposing he went and he ate a very high salt diet, or he forgot to take his diuretic, chances of gadbad are there. The safer ones would be sitagliptin as proved by TCOS, and also Gemigliptin as proved by all the other data. And one of the safest ones for LV function would be the SGLT2 inhibitors actually. Because
your personal opinion about the teneligliptin is not being included in the list because it is from Japanese molecule.
No sir, not because it is Japanese, but I do not use, and the reason is that there is no evidence. And in this hall I can say openly, in another hall I may not say, but we are not very proud of our DCGI. The way they approve saroglitazar, they approve berberine, they approve hydrochloroquine, and then they approve teneligliptin and teneligliptin plus metformin. That is not a nice way of approving drugs. And it is just that individually none of us have a voice loud enough to be heard. But and again, if it was another hall with different nationality, I would never say this. But in our own people, we can say the approval process is highly flawed.
Thank you, Dr. Kalra, for a nice interaction as well as a nice talk.